Good day, everyone, and welcome to today's American Lung Association Asthma Care Coverage Project, a comprehensive look into state Medicaid coverage and barriers to access of asthma guidelines-based care webinar. At this time, all participants are in a listen-only mode. As a reminder, this call is being recorded. I will be standing by should you need any assistance. It is now my pleasure to turn the conference over to Era Janoyan. Please go ahead.
Great. Thank you. Hi, everyone. On behalf of the American Lung Association, we respectfully thank all of you for joining us on our webinar today. This is a great opportunity to engage with diverse stakeholders and to discuss the American Lung Association's Asthma Guidelines-Based Care Initiative, which aims to improve asthma health outcomes for Medicaid populations. We'd like to take this opportunity now to introduce ourselves. My name is Ara Janoyan. I'm the Director of National Health Policy with the American Lung Association. I engage in the Lung Association's policy initiatives surrounding Medicaid, Medicare, and Affordable Care Act implementation for asthma, COPD, and lung cancer. I am also the project manager for the Lung Association's Asthma Guidelines-Based Care Initiative.
Hi, everyone. This is Tanisha Williams. I'm the Health Policy Manager at the American Lung Association. I research and assess state Medicaid plans regarding guidelines-based care coverage for asthma, and I work closely with Ara on this Asthma Guidelines-Based Care Initiative. I also work on the Lung Association's Tobacco Policy Project. Now I'm going to get started on the discussion. You can see on our first slide. I'll first provide everyone with a brief background of the development of the Asthma Guidelines-Based Care Initiative and continue with the initiative's objectives, methodology, results, and next steps. With millions of Americans, including a significant number of children living with asthma, it is imperative to ensure access to treatments and services that will help reduce the burden of asthma and improve asthma health outcomes. Here we can see the impact that the burden of asthma has on hospitalizations and school absenteeism. Now, if you take a look at the background, the idea for the asthma initiative the asthma initiative initially emerged from the Tobacco Cessation Policy Project. In 2008, the Lung Association launched a Tobacco Cessation Policy Project where it began to collect Medicaid, tobacco cessation coverage, and data. The project tracks coverage and barriers for all 7 tobacco cessation medications and all 3 forms of counseling for all 50 states and DC under Medicaid fee-for-service and Medicaid managed care. I share this background with you so you understand the long-standing experience that Lung Association has in collecting Medicaid coverage data, and that experience has fed directly into our new Asthma Guidelines-Based Care Initiative. Now, if you take a look at the next slide, you can see the Lung Association has recognized the importance of adherence to practices in reducing the burden caused by asthma. We strongly support and believe the care for asthma patients should be based on recommendations in the National Asthma Education and Prevention Program, otherwise known as NAEEPP, Expert Panel Report 3 guidelines, which are provided here. Now I'm going to turn it over to Ara.
Great, thank you. In 2014, the American Lung Association launched its Asthma Care Coverage Project to reduce the burden of asthma and improve the health of people with asthma through increased access to medications and health services. Despite the establishment of the NAEPP guidelines that Tanisha mentioned earlier, a gap remains between what is known to be best practice in improving asthma outcomes, what is being covered by payers, including state Medicaid programs, and how some providers care for their patients. In 2015, with funding from the Center for Disease Control and Prevention, National Center for Environmental Health, the Lung Association created our Asthma Guidelines-Based Care Initiative and began to carefully research state Medicaid coverage and related barriers to access of asthma care. The burden of asthma is especially significant among families and individuals with low income and limited resources. In fact, Medicaid was the most commonly expected primary payer for asthma-related hospital stays for both children and adults aged 14 to 44. The Asthma Guidelines-Based Care Initiative provides state Medicaid asthma care coverage data on 23 of the CDC-funded National Asthma Control Program states. Outcomes of our initiative include the increased availability of state Medicaid coverage data that will increase the understanding of the gaps or deficiencies in coverage and to increase public health stakeholder engagement toward improved access of asthma care. In fall 2015, the Lung Association convened a group of key stakeholder organizations representing a range of experts to discuss and develop the Asthma Care Coverage Initiative benchmark document, which reflects the 7 key components of the NAEPP-based asthma care coverage for state Medicaid programs. The stakeholder organizations are included here on this slide. The Asthma Care Coverage Initiative tracks 7 key components of coverage and 9 related barriers to coverage. Here you can see a list of the 7 key components of coverage. For quick relief medications, to note, we are tracking 4 medication types within 2 medication classes in quick relief medications. For controller medications, we're tracking 20 different medication types within 9 medication classes. For medical devices, we're tracking nebulizers, peak flow meters, and valve holding chambers. For allergy testing, we're tracking both coverage of skin and in vitro testing. And we're tracking allergen immunotherapy coverage, home visits and interventions, as well as self-management education. The following is the list of the barriers that we're also tracking. As you can see, they range from age, barriers related to age, durable medical equipment, co-pays, prior authorizations, quantity limits, specialty visit limitations, step therapy, and durable or eligibility criteria. Ultimately, the benchmark for medications are to have at least 1 medication per medication type without barriers, and the benchmark for the remaining 5 criteria that we're tracking are to have them covered without any barriers. The data collection process is both intense and comprehensive. The entire methodology is provided on our website. Generally, our methodology includes the careful review of Medicaid managed care and fee-for-service member handbooks, provider manuals, formularies, preferred drug lists, and any relevant documentation. Additionally, as part of our methodology, we established state Medicaid contacts to help in the confirmation of our data findings. In the coming year, to note, we will also collect state Medicaid coverage data on the remaining 27 states, DC, and Puerto Rico, as well as to continue updating our state data on the existing 23 states. In going through the data collection process, the main challenges faced were the following, or at least 2 of the main challenges: transparency and uniformity. As far as transparency, our methodology revolves around reviewing publicly available documentation on Medicaid managed care plan and fee-for-service program websites. In light of this, there is variation between and among states with the extent of information that is available for Medicaid enrollees and to gather our state Medicaid coverage data. For uniformity, in light of the results that we'll share next and which are available on our website, the challenge becomes how to ensure equitable access of asthma guidelines-based care coverage between and among states. The following 3 slides will provide actual state data report summary examples to illustrate the variation in coverage and barriers. And we're using medications as an example for this slide. More information on the interpretation of the state data report summaries can be found in our glossary on our website, along with our state data report summaries for all 23 states. Here you could find actual state data for Connecticut. Connecticut has coverage, as you can see, of all quick relief and controller medications for all Medicaid enrollees. Although, as noted earlier, we are tracking 20 medications in controller medications, this is just a brief example of a few. But Connecticut has coverage of all medications for all Medicaid enrollees. But you'll see that there are barriers to attaining some of the medications. This following slide is actual state data for each of the following states: Maine, Massachusetts, Missouri, and Wisconsin. These states have coverage of all quick relief and controller medications for all Medicaid enrollees as well. However, you'll see that here, each of these states has barriers to access all of the medications. And on this last slide, this is actual data, state data for New Mexico. Here you'll see a variation in the level of coverage as well as the extent of barriers to access medications. Some medications are available for all Medicaid enrollees, as noted with a green check. Other medications are not available, as noted with an X mark. Or some medications may be available to some Medicaid enrollees, as noted with a yellow triangle. And at this time, I'd like to turn it over to Tanisha.
Thanks, Sarah. Now this is the fun part. The states highlighted in the seafoam blue, as you can see up there, are currently funded by the CDC's National Asthma Control Program. There are 23 states altogether, and they are Maine, New Hampshire, Rhode Island, Vermont, Massachusetts, Connecticut, New York, Pennsylvania, Ohio, Georgia, Florida, Indiana, Michigan, Illinois, Wisconsin, Minnesota, Missouri, Montana, New Mexico, Utah, Oregon, California, and Hawaii. Okay, now we're going to go in a little bit more detail of actually what this means. Right here is the map for the quick release medications. And in the next few slides, we're going to talk about the 7 maps that describe each state Medicaid coverage of the 7 categories of treatment and services. If you notice the map legend, we have green, red, yellow, purple, and white. The red indicates covered without barriers. We are able to determine this on our state data report summaries where the coverage results for all items being tracked for the category of treatment and or service should be green checks. The barrier results for all items being tracked should all have no barriers. This is the gold, or because it's American Lung Association, it's the red standard. Ideally, we strive to have the map that is all red, where the treatment or service being tracked is covered and has absolutely no barriers to its access. The green shows that it is covered, but there may be barriers. So green is good, but we want to aim for the best. This was translated by state data report summaries where the coverage results for all items being tracked for a category of treatment or service should be green checks. But the barrier results do not all appear to have no barriers. Yellow indicates some coverage. Some categories of treatment or service have multiple items being tracked for coverage. For example, medications, devices, allergy testing. For categories, the items being tracked will have a mix of green checks, yellow triangles, X marks, while the barrier results in the report summary do not all appear as no barriers. I'll repeat that again. The report summary do not all appear as no barriers. For all other categories of treatment services, including allergen immunotherapy, home interventions, and self-management education, the coverage results in the state data report summary as seen as yellow triangle, while the barrier results do not appear as a no barrier. So what does this mean? Some Medicaid plans in the state cover that particular treatment or service, and some do not. This is okay. We'll accept this for now, but again, we want to strive for green and ideally red, the American Lung Association red. Purple means there is no coverage, where the state data report summary will show the category of treatment or service with coverage results as all X marks. The barriers are not applicable because the items are not covered. This means there is no state Medicaid coverage of this category. We want to shy away from this color because this means that a particular treatment or service is not covered at all. Lastly, white means that data is not yet available, and with your help, we aim to fill in the entire map next year. So in this slide, fortunately, for all 23 states, we have some coverage, but there is not a state that covers quick release medications without barriers. But we do have 7 states, noted in green, that cover quick release medications with some barriers. Okay, and the next one we have controller medications. As noted in the previous slides, controller medications have 20 medication types with 9 medication classes. So ideally we want the map to be all red, but we do understand that this may take some time. However, the map isn't looking too bad with at least some coverage in most states, and 5 states that are fully covered but have barriers. Okay, now in this map we're talking about devices. Now this slide shows which state has nebulizers, peak flow meters, and valved holding chambers in their coverage. 7 green states out of 23. But unfortunately we do have 1 state that does not cover other devices. Next slide, we have allergen testing. Now we're getting warmer. Ohio and Connecticut have the right idea. They both have skin testing and in vitro testing covered with no barriers. Also, take a look at those green states. Right? Conversely, we have 2 states that do not cover allergen testing. So we can do better. Okay, and next slide we have allergen immunotherapy. Ohio and Connecticut are now joined by New Hampshire for covering allergen immunotherapy with no barriers, but let's not forget about those green states. And California and Utah are yellow. Okay, now we have home visits. If you notice, there were a couple of changes to the map. 10 out of 23 funded states are purple, which means home visits are not covered. But we still have 4 states that have coverage without barriers: Massachusetts, Rhode Island, Connecticut, and Ohio. We also have 3 green states that cover home visits and interventions, though with barriers: New Hampshire, Maine, and Wisconsin, and 6 yellow states. So we really need to work on getting home visits covered. Lastly, we have self-management education. This map shows that only 5 states of the 23 funded states have no coverage. But we do have 5 red states that offer self-management education without barriers. Not bad, but we still have a ways to go. And now I'm going to turn it back over to Ara for the database.
Great, thank you. In 2016, we'll have the following information accessible online to provide further details on the state data report summary tables shown earlier. Here you'll have information on the criteria being tracked to the left and the barriers running across on top. For each criteria, you'll have the opportunity to understand the level of coverage as well as the type and extent of the barriers per criteria in a state. So at this time, I just want to give a few examples of how to interpret the database. Once again, more information on how to interpret the database is found in our glossary online. So as you can see here, for albuterol sulfate, for example, you'll see a Y for yes covered. This means that all the plans, Medicaid managed care plans and fee-for-service, cover albuterol sulfate for all Medicaid enrollees. The next question becomes, of the plans that do cover it, which in this case all of them, what barriers exist as access to the albuterol sulfate? And here you'll see that there are none across the board. There are some barriers that are not applicable, and those you'll find in other parts of the database for the items that we're tracking. For levalbuterol, we'll see a VAR for varies by plan. Here, the coverage for levalbuterol varies by plan among the managed care plans and fee-for-service. Next question will be, of those plans that do coverage, what are the barriers that exist? And this is all hypothetical data and not applicable to any particular state. But here you'll see that barriers exist on, for all the plans in Medicaid managed care plans and fee-for-service, with the exception of the non-applicable barriers. Ipratropium would not be covered, so the barriers would be not applicable. And in ipratropium with albuterol, you'll see an NAV for some barriers. That indicates times when there was not enough information available at the time to determine whether that barrier exists for Medicaid enrollees. So here you could see a mixed sort of set of results that's possible. And for the last item there, you could have coverage and you could have a variation of barriers for access to care for that item. The data on state Medicaid coverage of asthma guidelines-based care is now available, and the state Medicaid contacts have also been identified by the Lung Association. This is where the opportunity for state coalitions comes in. While these ideas go a little beyond the scope of this initiative, we wanted to leave you with some suggestions on what some next steps might look like. The objective now is to foster a dialogue and to increase collaboration between diverse stakeholders, including state asthma and Medicaid programs, in order to educate decision makers on the significance of asthma guidelines-based care to improve patient outcomes. The first focus is stakeholder mobilization and partnership building. Here, you may build on existing asthma coalitions in your state and further expand your outreach by including community groups and organizations that represent key stakeholders, including physicians, payers, hospitals, and school nurses. For example, identify your state asthma coalitions, your state lung association charters, and also determine if your state has a Medicaid coalition that focuses on improving the health of Medicaid populations. The second focus might be to have the stakeholder groups mobilize and determine coverage priorities. By having a diverse set of stakeholders in your coalition, you can assess the urgent needs that must be met in your communities and state to improve the health of those who live with asthma. For example, your coalition might determine that while coverage is lacking in all 7 areas, there is an urgent need for increased self-management education or access to medical devices. The third focus is to educate the decision makers on the significance of increased access to asthma guidelines-based care to reduce the burden of asthma and improve asthma health outcomes. For example, your ever-growing coalition might create sign-on letters that identify the needs and explain the problems with the lack of access to guidelines-based care. Letters with an array of logos, including the one shown here from another project the Lung Association has been working on, always gets attention. And at this time, we'd like to open it up for questions.
If you have any questions, please feel free to type them in the box, the Q&A box, and we will get to them promptly. So it looks like we've got a first question. Will the slides be available? So I believe we do plan to make the slides available. We'll also be having a recording of the webinar that will be available probably within about a week or so. So we've got a couple other questions. Ara and Tanisha, you guys talked a lot about different plans in the state. About how many plans are in each state? Do you have a rough estimate?
Well, the number of plans do vary between the states. So with California, for example, has about 24, New York 19. Some states have an 18 or 19, although some other states may have lower single-digit plan numbers. So it does vary by plan.
Great. Looks like we've got another question. So let's, if you're looking at this and looking at the data, I'm feeling a little bit overwhelmed kind of with everything that I'm seeing here and whatnot. Where is a good place for me to start? I don't know much about insurance coverage in general.
Sure. So a great place to start would be you can access additional materials on our webpage, lung.org/asthma care coverage. There you'll find our benchmark document for the Asthma Care Coverage Initiative, which we discussed earlier. That would be a great place for everyone to start to read further up on our project and initiative and to get a better understanding on the background of our initiative, the categories that we're tracking, and the list of barriers as well. And that gives further elaboration on the actual 9 barriers that were listed earlier. Once you have a good grasp on that, you can then go into our database, which is linked on that same page, and access the state data report of your state or any other state if you'd care to look at any data reports for other states. Then it would be a great idea to reach out to us for further discussion and be happy to discuss with you and your asthma coalitions to determine what the urgent needs in your state would be and to discuss any potential next steps.
Great. So we've got another question. What are some of the barriers you guys saw with coverage of home visits?
Well, for home visits and interventions, it goes with every item that we're tracking, or excuse me, category of treatment or service that we're tracking. As noted in the prior slides with the database, with hypothetical state data, there are 9 barriers that we're tracking. So any combination of those 9 or all could be applicable to home visits and interventions. It does vary by state, of course. Some states, as you'll see on the state data report summaries online, for those states that have coverage, whether it's whether by a green check or by a yellow triangle, which shows varies by plan, the next question will be, of those plans that do coverage, what are the barriers that are associated with access to home visits? And it varies between states. So some states may have a age restriction to home visit interventions, or another state may have a restriction with regards to the amount of visits made done. It could vary between states. But again, that's something with further detail on the database, which will be made available later.
Okay, great. Another question, can the state-specific data be shared with program partners?
Sure. Well, the database information will be once again available, and any further details that partners would like to know about state-specific information, obviously, we'd be happy to share with.
Great. We got another great question, and for states that are covering home visits and self-management education, did you collect data on the mechanisms for covering them? For example, billing codes and whatnot.
Well, as part of our methodology, which once again available on our site, which gives you further details, is that there are, we go through the publicly available documents. So if it's through the member handbooks or provider manuals, but at the same time there are CPT codes that are specific to these categories of treatment or services that help us determine, if not by way of member handbooks or provider manuals, then by way of CPT codes.
Great. Just another quick process question. How did you obtain your information? Was it a direct ask of the MCO? And I think you kind of went into this a little bit, but maybe just some clarification.
Sure. So in order to obtain our information, once again, it's publicly available information. So once we determine the number of plans per state and specifically what those actual plan names are, then we'll go through each health plan's website. And from there, we'll gather the information that's available. So if it's the drug lists, member handbooks, provider manuals, any other relevant documentation that'll help us determine coverage of the items that we're tracking. And after that, we, as part of our methodology, as noted earlier, we established state Medicaid contacts between these 23 states. And after we gather our findings, we then communicate with them and have their assistance in helping confirm our data findings.
Hey, Tanisha, it looks like somebody really liked your maps. Are they going to be publicly available?
Yes, they are. They will be available, and I believe they are already available online. So, yeah, check those out.
And that website was, again, lung.org/asthma care coverage.
All one word.
One word.
Great. So this next question, when you're referencing home visits being covered, are you talking about states that have plans in place for reimbursement by MCOs?
Well, as part of our methodology as well, we are going through state plan and approved state plan amendments to determine what of the categories that we're tracking are a part of the Medicaid state plan. And, we're basically going, so the answer would be yes, if there is, if we're going through a plan site and there are documentation that say, home visits and interventions. And again, home visits and interventions are applicable according to our benchmark document and how it's described of how we're tracking it, which is specific to addressing the asthma triggers in the home. And there is further information on our benchmark document, the level of components that are required as part of that. So that is also another sort of granular detail that we want to make sure is covered if it is stated as home visits.
Great. And so another question, when do we expect to have the other 27 states, Puerto Rico and DC data?
We're actually aiming for that for next year. So we're planning on doing all the states and then redoing the 23 states we currently did now. Yeah, so we'll update the 23 states we have now, and we will also do the 27 states.
Okay, so we've got another question that's very interested in kind of more the details of the data. And so just asking, for example, when it says varies by plan, will states be able to get into the specifics to see kind of some more detail of what varies by plan means?
Well, with varies by plan, so on the database, it'll be indicated as varies by plan, but if there are specific questions as to, what that sort of entails by way of the plans in the state, you can always feel free to email your inquiries, and we do have the contact information available at the end of our webinar. Well, I guess it's already there. So you can always email us at asthmacare@lung.org, and we'd be happy to provide further information.
Great. Looks like we've got another question. Can education, I'm assuming we're talking about the self-management education, be provided by hospitals or independent programs, or do they have to come from the Medicaid source?
Well, according to the methodology that we're doing now, it would be through the, if it's covered under Medicaid by way of the managed care plan, so it would be within the Medicaid source.
But so as long as they pay for it?
Correct.
Great. Okay, this looks like a similar question. What does coverage without barriers really mean? Does that mean the health plan will reimburse coverage for various supplies? Or is there a great resource we can direct somebody to talk about kind of what some of these more technical definitions mean?
Correct. So again, just very broadly, coverage without barriers, it means that the category of treatment or service that we're tracking, whether any one of the 7 or the sort of items within the medications, specific medications or allergy testing or devices, if they are covered, if that category is covered without any barriers, that means it's accessible without any one of the 9 barriers that we're tracking. And additional information, again, once can be found on our methodology.
Okay, so we've got another quick question. Are you familiar with the CDC 618 initiative and proposed asthma service included in that initiative? Yeah, so, and I actually will answer that question. Or Erica, do you want to answer that one?
Go ahead, Ann.
Okay, so we actually are very familiar with that. ARA has actually talked to some of the CDC states about kind of what they can do with their asthma coverage, and we have been connecting with them over the past couple of months. So it's been a really great initiative, and we're really excited about the 618 project and to be part of it. And again, if you guys have more state-specific data questions, we're more than happy to talk to you offline and via email. And we are working on the website link, understanding that some of you are having some trouble with it. Okay, so this is another question. When we looked at it, especially the self-management education, did you differentiate between wellness programs and disease management programs versus actual self-management education?
Sure. So with the self-management education as part of our methodology, once again, for self-management education, we're tracking only SMEs and not disease management. So if there were plans by way of publicly available documentation or even by way of confirmation with state Medicaid contacts, disease management was not part of our methodology to include as part of SMEs.
Okay, great. And I think we have some confirmation on what that Vanity URL is. So I believe, Tanisha, you have it. If you want to just try to read it off again slowly so everybody can get it. And if not, if you've got any questions, please feel free to email asthmacare@lung.org if you're still having problems. But Tanisha?
It should be lung.org/asthma-care-coverage.
And it's currently on the site. So if you're still having problems, let us know. There might be a glitch.
So if they're having difficulty, yeah, so lung.org/asthma-care-coverage, yeah.
Great. And so someone asked if it was possible to get contact information for the people that we had reached out to. And so we're providing that list to CDC, and state officials will need to talk to CDC to get that information from them. But we encourage you to reach out.
And it looks like there's a question, will you do a comparison of self-funded insurance plans versus Medicaid?
Okay.
Well, with, the plans that we're tracking right now is all-inclusive of the fee-for-service and Medicaid managed care plans. So whenever you do see the results as, if it's covered or it varies by plan or it's not covered. So distinction in the future could be made as to how fee-for-service and Medicaid managed care plans can be differentiated.
Great. And again, just interested to get down some of those details. Does the document detail the specific health plans by state that were surveyed? So I think this person is looking at, does it go into plan-specific information? Kind of, again, I think getting into that varies by plan question.
Correct. So once again, the information provided is it compiles the information across the health plans and fee-for-service and provides the answer varies yes or not covered collectively. So there is no specific health plan information that will be available to you. But once again, you could always email at asthmacare@lung.org if you have any state-specific questions to that extent.
Great, thanks. And again, we are trying to get through all the questions. If you feel your question hasn't been answered sufficiently, please feel free to give us an email at asthmacare@lung.org, which is right up there on that website. And it looks like we don't have any more questions, so we'll give it one more minute for people to ask last-minute questions. Okay, so we are going to wrap it up. I'm going to turn it back over to our friends at OneSource for any closing remarks, or turn it over to our for some closing remarks.
Sure. So once again, and this, or I guess there was a prior slide just to show the next 27 states, but the Lung Association, of course, looks forward to working more closely with state asthma coalitions and state and local public health stakeholders to increase access to asthma guidelines-based care and to ultimately work to improve the health of Medicaid populations with asthma. We once again respectfully appreciate the opportunity to present our initiative to you all. Please visit our website that you see here, lung.org/asthmacarecoverage, to further explore our data findings and to find additional materials on our project and initiative. Please contact us if you have any questions at asthmacare@lung.org. Thank you.
And this concludes today's program. Thank you for your participation. You may now disconnect.